right, guys, I think I'm going to start chatting so long, just because it is a fairly long talk. And the link will be available a little bit later. Again, Dave Frederick will send it out. So as you can see, so today's is again the traumatic brain injury and ICU management part 2 talk. We did the part 1 talk about 3 weeks ago. We last time looked in part 1, we looked at the epidemiology, the pathology of TBI and how we split primary versus secondary injury. And then we spent basically the rest of the talk going through some CT scans, how to approach reading a normal CT brain, with the caveat that I'm not a neuroradiologist, that I have a background in neurosurgery. So just keep that in mind. And then we spent quite a bit of time looking at some common trauma pathologies on a CT brain. And basically this talk kind of got modified a lot when I spoke to some of the anesthetic JCs that have recently finished their part 2 exams. And kind of we've added a lot of bits and bobs to kind of help prepare, especially the guys prepping for part 2s, looking at the CT scan pathologies and how to read a CT brain, just like on a very basic level. And then also now this second part, we're going to focus more on the management of the TBI, and we're going to spend quite a bit of time looking at TBI monitoring, chat a little bit about autoregulation, and then specifically look at the waveform patterns that we get in ICP monitoring. And then specifically because I know that you guys get asked a bit about the Lundberg waveforms, we'll touch on that. And then we will spend the majority of the time looking at actually the treatment of TBI, and then just finishing it off with a word or two on the outcome and prognosis of TBI. So then just to kick off, the management of TBI, it still does include, it starts from the moment that you get a history about the patient, from the mechanism of the injury, whether or not that happens to be the paramedic that brings the patient in, or the family member that arrives with these patients. It's just kind of just important to remember that these patients with the severe head injuries often obviously can't give a history of themselves. So it's important that you try and get as much of the history from the personnel involved with bringing the patient to you, or that were the first responders, because a lot of the information that you get from these paramedics and first responders can be quite useful in helping you decide the severity of the injury, the likely prognosis, and how fast you need to act with certain things. It helps to decide, to look at the spectrum of injury that the patient has. And the mechanism of injury is also very important, because it'll also then give you an idea of if it's a high velocity or low velocity injury, and what kind of injury you can expect the brain to have sustained. Important to still go through a proper examination for these patients, and the ABC or ATLS principles still hold for these patients. And we'll talk a lot about in this talk about preventing secondary brain injury. And like, you can't even start to try and prevent secondary brain injury if you don't actually do your ABCs or your ATLS principles properly. I mean, you can't prevent a secondary brain injury if you don't secure an airway and stop the hemorrhage and ensure a good blood pressure, and all of those things that you would do as basic principles. And we'll go through a little bit about how we assess the conscious level, how to look for signs of basic skull fractures, and why we are so obsessed with pupil responses and eye movements, and also to document early on if a patient has limb weakness. Are they able to move both their arms, both their legs, or do you suspect even from the start if there's a unilateral or a mono limb plegia or a paraplegia. It has a lot of important, not only medical legal implications for a patient's stay, but it also has great implications for patient's management in terms of whether or not you now need to rush somebody for an MRI scan, because all of a sudden now on day 7 somebody has noticed that the patient's paraplegic when they were actually just not examined properly in the beginning, and that was actually part of their initial presentation. Then we'll run through some of the investigations that we do commonly for patients with traumatic brain injuries. And then, as I said, we'll spend quite a bit of time talking about the treatment of TBIs. So the most important thing in the management of a traumatic brain injury patient is to work towards preventing secondary brain injury. Unfortunately, there's very little that we as doctors on the receiving end of getting these patients can do to prevent the primary brain injury, but there's a lot that we can do to prevent secondary brain injury and worsening of their insults. So in terms of management of TBI, this talk is not meant to target an undergrad level. So we really are just going to talk about a little bit of nuances around examining patients with TBI. We're not going to do a full third year or fifth year medical school examination run through. There's just a couple of things that I want to mention around GCS examinations that we commonly pick up that registrars or MOs starting off may misunderstand or misinterpret or just do like, misunderstand. And then a few words on herniation syndromes. And then we'll look at the investigations and how we choose which patients we monitor and which don't need monitoring. And then importantly, we're going to chat a little bit about the Brain Trauma Foundation guidelines, which is kind of part of the Bible for management of patients with TBI, and then also a few other points on treatment of TBI. So just two things that I really want to comment on when you're assessing a patient with for a Glasgow Coma score is I often find even registrars still having difficulty with differentiating a motor score of 3 and a motor score of 4 because both of them are flexion to pain. I've typed out the whole Glasgow Coma score so that you're not tempted to use like a 1970s version of it, like using now out of fashion words like decerebrate and decorticate movements. These are the ways that we kind of used to describe motor movements when you're assessing GCS. So just on the motor side, so a motor score of 6 is fairly easy to elicit, and that's when a patient can obey commands, motor commands, and whether or not they're paraplegic or quadriplegic doesn't affect that because patients can still obey motor commands with facial muscle movement. So if you ask somebody to close their eyes, they can close their eyes. If you ask them to open, they can open. If you ask them to open their mouth, they can open their mouth. That's still an M6, even if they're a high spinal cord injury with a quadriplegia. Localizing to pain is also fairly simple to elicit. You just must make sure that your pain stimulus is an adequate pain stimulus so that you don't necessarily score somebody an M4 when actually they are an M5 and the problem was your pain stimulation wasn't adequate enough. So now to differentiate between an M3 and an M4, the major difference between an M4 and an M3 is the tone of the muscle flexion. In a patient with an M4, it's a normal tone and it's almost just like they're too weak to localize to the sternum or the clavicle or the eye, depending on where you are giving them their pain response. But an M3, you would see they've got an increased tone response if they can move their arms or legs. You'll see it's a very spastic type of flexion, and that's an M3. One of the things I was taught when I was still a very junior registrar to look for one of the subtle signs. They're not always there, and if it's one of those things that if it's not there, then it's not really that helpful. But when you see it, then it's kind of a giveaway for an abnormal flexion response. That patients do tend to flex their thumbs inwards, and I don't know if you guys can see me, like it's an inward movement and they're really very spastic and then they start to flex, and it's just a very, very abnormal spastic movement, and that is it's a major difference in their prognostic outcome, whether or not they're an M3 and M4. It just kind of tells you a little bit about the level of their injury in terms of the cerebral injury. The eye and the verbal score is exactly as you've learned it at undergrad level. And I'll say a little bit more about that a little bit later when I talk about GCS and Glasgow outcome scales. So GCS is useful to use because it's fairly simplistic. It's easily reproducible. And it helps with not only the clinical assessment of a patient's condition, but it also helps you to monitor and track whether or not a patient from a neurological point of view is improving or deteriorating. We also use it to classify traumatic brain injury just based on a Glasgow Coma scale, and you can have a mild brain injury with a GCS above 13, a moderate traumatic brain injury with a GCS between 9 and 12, or a severe head injury, which is often the patients that we see coming to ICU with us, where their GCS is then between 3 and 8. The GCS, in terms of motor score, there's a lot of work that's been done around whether or not you can use GCS to accurately prognosticate patients in terms of their 28-day survival or mortality, as well as then long-term follow-up in terms of 3 and 6 month mortality outcomes. And there's actually not so long ago a group from KZN and WITS that collaborated, and they actually published in the SAMJ in terms of validation of the simplified motor score. So just the motor component of a GCS, if you can use that alone to kind of use it to prognosticate for 6-month mortality. And they've kind of published these figures that if you're an M3, you've got a 56% survival, an M4, 80% survival, M5, 95% survival, and M6 of 98% survival. And there is also quite a bit of literature on using a Glasgow Coma, what they call a Glasgow Coma-P score, which is then the pupillary reflex score. And that's also actually been validated, although we don't use it that much. We tend to kind of focus more on the motor score to kind of help prognosticate patients. Then just a word on herniation syndromes. Obviously, when you have a patient with a significant severe traumatic brain injury, depending on which parts of the brain herniate, you can actually pick up on it before they've even gone for CT scanners, although we don't really have that issue here at Grootegeluk because we have very easy access to 24-hour CT scans. So very often, it's not uncommon that we get patients referred to us with a CT brain scan before they've even had their LODOX done. So this is maybe more important for peripheral hospitals where they don't have 24-hour access to CT scans, and you can actually pick up on some herniation syndromes just on clinical signs. Now, it depends on which part of the brain is herniating into which compartment. It will give you different clinical signs. And I've left this little table here so that you can study it at your leisure. But just one thing that I did want to actually just put some attention to is just to take note of this transtentorial, because sometimes we get asked, like in trauma or even in ICU, you know, if you've got a localizing sign and you've got a right blown pupil, why don't you just go and do an emergency burr hole and decompress? You don't have to rush a patient. You must just be aware that sometimes if you've got a transtentorial herniation of the uncus of the temporal lobe down the tent towards the post fossa heading towards foramen magnum, often people will think, yeah, but the ipsilateral pupil will blow, and you know, ipsilateral pupil will blow and you can decompress that side so easily. But sometimes it can actually also compress the opposite side of the uncus, and it can give you false localizing signs so that the lesion isn't actually on the side that you think it is. So just be aware of that phenomenon that you can get. So it's not, you know, it's not safe to practice emergencies, neurosurgical procedures just based on clinical signs, just because you have a 50% chance of being wrong. This is just another example of the different types of herniation syndromes that you can get, and you can actually get calvarial herniations with quite significant comminuted depressed skull fractures, where the brain can start to swell, and this will also give you different types of clinical signs depending on the part of the brain that is involved. So if the depressed skull fracture is overlying a motor strip area, you can have arm or leg weakness, including facial weakness, depending on where your little homunculus man is sitting in relation to the fracture site, and then different, obviously, respiratory and blood pressure hemodynamic instabilities when we're moving towards brainstem compression herniations. This is just the pathology slide of an uncle herniation. I just thought it was quite interesting to see that this is actually the medial part of the temporal lobe called the uncus that's actually dipped down under severe trauma. You can see this is almost like a burst posterior temporal lobe over here. So you can imagine that quite significant amount of swelling caused uncle herniation, and probably a unsurvivable injury led to herniation and patient's demise. Then just also a few slides on Cushing's reflex. I've actually typed this out now because I realized that some of the guys might want to use this for study notes, and then you don't have to go back to textbooks and look this up. It's already here for you guys, and you can just study it straight from here. But so the Cushing's reflex, proposed by Dr. Harvey Cushing already in 1901. So it's believed that the dramatic increase in blood pressure was a reflex to brainstem ischemia seen in patients with an acute increase in intracranial pressure, typically caused by intracranial hemorrhage or mass effect from tumor with significant cerebral swelling. So if there's an acute increase in ICP, then you would see or appreciate this Cushing's reflex. It unfortunately has many names, and people refer to it either as the Cushing reflex, the vasopressor response, the Cushing's reaction, Cushing effect, or the Cushing's phenomenon. And just to realize that it is a physiological nervous system response to an acute elevation in ICP that results in this Cushing's triad, where you see this hypertension with this widened pulse pressure, where you have a very high systolic blood pressure, low diastolic blood pressure, and then usually followed by a bradycardia with irregular breathing. There are some articles as well that kind of describe the Cushing's reflex according to stages, but just to know that these stages actually happen quite rapidly. So we usually see it when it's already in this later stage. It's not like, you know, you're going to be in the first stage for a few hours and then you're going to progress to the second stage. These are things when it starts to happen quite rapidly. And it usually means that brain herniation and brain death is probably quite imminent if you don't act on it quite quickly. So first stage is usually described then as a blood pressure and a heart rate rise in response to a sympathetic activation to overcome the increase in the intracranial pressure. So it's your brain's response to try and desperately overcome the resistance of the acute intracranial pressure to try and improve the cerebral blood flow. So the body's reaction to that is to try and increase the mean arterial pressure to overcome that resistance and kind of rescue the blood flow or perfusion through the brain and improve oxygen delivery. So that sympathetic response allows then for brain perfusion as long as the ICP is not too high to overcome. And for the brain to remain adequately perfused, then the mean arterial pressure must then be maintained, obviously higher than the ICP. Then a second stage that progresses quite rapidly, the hypertension will continue to be present, but then the patient becomes bradycardic rather than tachycardic. And that, there's some differing opinions on that, on the mechanisms that leads to kind of this bradycardic reflex. The prior thinking was that the increase in blood pressure led to activation of the baroreceptors in the aortic arch, which then triggers a parasympathetic activation and a resultant bradycardia. But there have also been some papers published looking at or proposing that chemoreceptors outside the brain doesn't actually participate in this stage, and the bradycardia actually results from compression of the intracranial segment of the vagal nerve. So, and then also just to realize it's a late stage when you start to see this. It's usually a terminal sign with imminent brain death probably to follow soon after. And then in the late stage with the brainstem dysfunction secondary to the high ICP, where the tachycardia becomes a bradycardia, it will also then be followed by irregularity in the breathing pattern. And different people describe it differently. I don't think it's that important to know exactly what the breathing pattern looks like and how it changes. I think it's just important for you to recognize that there is irregularity in breathing, but by that time, this is almost the last stage of the Cushing's reflex. And if you haven't realized it at this stage, it's probably too late to do anything after this. And usually then the terminal event of this is then apnea and brain death. All right, and there's just a little picture then for you guys to remind yourselves for somebody or some people that like to use like little mnemonics or pictures to help you guys study. That just to remember, the Cushing's triad is almost the exact opposite that you see in patients that develop shock. So I've just put that little picture there for you guys, and this is actually what it looks like for you guys that have been in D12 about probably now about 3-4 weeks ago. This was one of our actual patients in D12 polytrauma that fell off the back of a bucky. And we were phoned the morning at about 6 or 7 o'clock, just before the ward round was about to start, and the patient had this response. You can appreciate the significant severe bradycardia with this hypertension. Still at this stage was breathing nice and regularly, and we just started him on hypertonic saline, and tried short burst of hyperventilation, which we'll talk about now. It's not a therapy to kind of treat acute raised intracranial pressure, but it is a rescue mechanism to buy you some time whilst you are doing other things to help sort out the patient. Okay, moving on to investigations. So most of the patients with severe TBIs, we do standard lab tests on them. They get a blood gas, and it's to look at things like the CO2 level, make sure that the patient's getting adequately oxygenated, that the HB is adequate. Our own unit here, we're trying to target an HB of 8 to 10, depending on the clinical status of the patient and if there's ongoing bleeding. We also look at the UNEs. Obviously, the sodium for us is a big thing, especially if you're struggling with significant cerebral swelling and you need to actually aggressively try and get the pressures down. We also do send off group and screens, just kind of as they come into theatre, into trauma, in anticipation that if they may go to theatre, there might be some blood loss. In which case they may already need some blood products in theatre. And then the INR on the TEG, I've only put there in brackets. We don't do it as a routine, but if there's a history of bleeding disorders or anticoagulation already on board, we will get it so that we can at least use targeted blood products to correct the bleeding disorders. Imaging, our patients here at Grootersdorp all have a Lodox done, especially if they come in as an intubated patient. And what's great is our Lodox really has good quality imaging, and you can actually do a very good C-spine, AP and lateral view on the Lodox itself, so you don't actually have to order C-spine x-rays afterwards. You can just kind of radiologically look at the C-spine on the Lodox. Skull x-rays have kind of largely fallen out of favor. We don't really need to do them, and they're not going to tell us anything more that we can't get from the CT scan. And like I've already said, we're lucky enough that we've got easy access 24 hours a day to CT scan. So it's not an issue for us to try and get a CT scan and appropriately assess a patient's injuries on radiology. MRIs in a setting of trauma is largely reserved for spine injuries, and we don't routinely do it on all of our spinal cord injury patients. We really only preserve MRIs for use if a patient has come in with a clear history of spine injury, they've got a neurological deficit, and then there's a clear documentation of an acute worsening in their spine or in their neurological examination. So then the things that we would be worried about is an expanding hematoma in the spinal cord, or even an abscess that expands a week or so down the line, especially with the penetrating spine injuries. Then an MRI is really useful to try and see if there is a mass lesion that you need to evacuate. But it has no real place in the acute setting for just routine assessment of spine injuries. CT scan indications that we use as part of the Western Cape head injury protocols. So we scan nearly all patients that come in with a GCS less than 15. All penetrating skull injuries, patients with focal neurological signs, patients that have CSF leak clinically, or patients that have persisting headache, but it's really almost any persisting neurological symptom after a history of a head injury, as well as patients that present with seizures after a head injury. So those are our main indications for CT scanning these patients. When do we decide to monitor traumatic brain injury patients, and how do we choose them? Also, again, in our Western Cape traumatic brain injury or head injury guidelines, it's very clear all of our indications for patients with ICP monitoring. So if you come in with a severe traumatic brain injury, so GCS less than 8 after adequately being resuscitated, you will be considered for ICP monitoring if there's some concern about cerebral edema, or the fact that if we can't actually adequately do neurological assessments on patients. This is especially problematic when we have polytrauma patients with significant chest or abdominal trauma, and they need to be sedated and on lots of analgesia and morphine, where neurological assessment then becomes tricky. It would be then safer to rather place a monitor if they've got a head injury, to make sure that you don't kind of get caught on the back foot with protecting, managing their head injuries. And then there's also some suggestion that you can use ICP monitoring post-neurosurgery after you've removed a large intracerebral hematoma. It will give you an early warning sign if there's re-expansion or re-bleeds of intracerebral hematomas, or recollections, especially of subdurals or extradural hematomas. But if you think you've done a good enough job during the surgery and you expect your patient to wake up fairly soon after the operation, that you could potentially extubate, then you don't need to place a monitor. That's usually the case with an extradural hematoma patient, not so much with the patients with a subdural hematoma that often has associated large cerebral contusions or hematomas. They often take very long, and then the use of an ICP monitor is a lot more useful. These are the monitors that we use at Groote Hospital. Our monitors at Red Cross are a little bit different, but in principle still remains the same. So we generally try to put in an ICP monitor as well as a Lycox monitor through a little bolt mechanism. The little, you guys would have seen the little thing that looks like a TV antenna that sticks out of the skull. And it just kind of helps you measure not only the pressure, but also to look at the brain oxygenation in that little area where the probe is. We always insert A-lines for these patients, because with an A-line and an ICP monitor, you can kind of work out what the patient's cerebral perfusion pressure is. And then if you've got a patient in theater that gets an ICP and a Lycox monitor, they should go to ICU with a CVP already in place. Not only do we use it for adrenaline if our cerebral perfusion pressure is low, but also when our ICP pressures are very high, we use it for hypertonic saline infusions. And obviously these patients go to ICU often running on propofol infusion, morphine infusions. So a central line is quite crucial in the management of these patients. Then obviously you can't talk about ICP monitoring in patients without saying something about autoregulation. So autoregulation, I think most of the guys listening to this talk is quite comfortable about what it is, but just to kind of recap it very quickly. So just to know that cerebral blood flow is dependent on the blood pressure and the vascular resistance, and the cerebral arteries can auto-regulate the cerebral blood flow within a range of systolic blood pressure, usually between 50 and 150, just as a ballpark. It will keep the cerebral blood flow constant. But outside of those ranges, so outside of severe hypotension and severe hypertension, the brain arteries start to kind of lose that ability to tightly auto-regulate the cerebral blood flow to kind of ensure a constant blood flow and good oxygen delivery. Just to know that this model is based on normal kind of brain function, normal cerebral artery function. And often we see it like in the neuro ICU that patients with significant head injuries have complete loss of autoregulation ability. So they kind of, as you push up their blood pressure to try and improve their cerebral perfusion pressure, you'll see if you push it up with adrenaline, I've got an example on these slides that I'll share with you, but all you actually do is just you increase the ICP with the blood pressure, and that's because that patient's ability to autoregulate is actually lost. So there's a couple of things that autoregulation does respond to. It's not only pressure. There's also metabolic signals that the cerebral arteries will vasodilate and vasoconstrict. And one of the most obvious ones are PCO2, where, you know, if you drop the PCO2, that's where the hyperventilation in some of the older guidelines came from. You will drop a patient's ICP if you hyperventilate them and you drop the CO2 significantly. But it's not actually a good drop in ICP. The numbers dropping might make you feel better, but it's actually all you're doing is you're causing severe cerebral vasospasm, and you're actually just turning the raised ICP into now an ischemic insult to the brain. So it really isn't a good thing to do, even though you are dropping the cerebral, the ICP pressure, you're not improving the cerebral perfusion. Then, okay, so these, the next couple of slides is more specifically for the part 2 anesthetic guys, just to talk a little bit about ICP waveforms. So this is not very dissimilar to an A-line tracing and how much you can infer from an A-line tracing. So you have this patient that comes to you with an ICP monitor in his head, and I hope you guys can see the cursor. So stuck in the subdural space, usually we secure ours here with a bolt mechanism that kind of secures the ICP monitor. Our ICP monitor gets zeroed in theater, depending on the type of catheter that we use. This is more the Codman monitor that we use at Red Cross, but you can see that little tip needs to be zeroed. This is the Camino monitor or the Integra that we use here at Grooteskier. And the thing is, you can't zero this thing in ICU like we would zero an A-line. We already have to zero it before we stick it into the patient's brain to get accurate measurements for patient. And then it goes through a little transducer, and you get this tracing on the ICP Integra box. And you can actually get quite a bit of information just looking at the type of waveform that your ICP tracing gives you. But you also need to have a well-placed ICP monitor to get these nice tracings. Sometimes if they're not placed nicely, you get a bit of a dampened trace, much like we actually get with A-lines. If A-lines are not placed adequately, then you get like this dampened A-line trace. So this is actually not an A-line trace. This is an example of an ICP waveform. There's also 3 peaks in the ICP waveform, and they are traditionally referred to as the P1, the P2, and the P3, where the P1 is the percussion wave, and it signifies the arterial pulsation. The second wave that you see is then the tidal wave, and that tells you a little bit about the brain compliance. It's a little bit different to lung compliance, so it's not the same thing. This is just the brain compliance and how much the brain can still actually withstand swelling before it kind of loses its compliance and has run out of space in the skull. And then the P3 wave, which is called the dicrotic wave, which just signifies the aortic valve closure. This is a few examples of different types of pathologies and how they would look on an ICP waveform if you've got a well-placed probe. So if you've got a very low P1 or percussion wave, it probably signifies that you've got a hypotensive patient. And the P1 wave and the P2 wave are almost at the same level. If you've got a significant spike, you usually also see that sometimes in the patients where they have the Cushing's reflex and they have that significant hypertension with then the wide pulse pressure and then the P1, P2. But I mean, this is not that waveform, the compliance of the brain would probably start to drop off significantly, and you would either have this tombstone kind of form where you've got critically raised ICP and the kind of the hypertension and the loss of brain compliance kind of becomes this large single hump, and it starts to resemble a tombstone, which is kind of where the patient is heading if you don't act on it very quickly. I've got a few clinical examples for you guys. These are all Lycox and ICP boxes taken from our own patients here at Grooteskier. So I'll try and talk you through a few of these examples so that you can at least see what I mean. So I've kept the pictures on the left-hand side here just as a reference point for you, but then I'll talk more a little bit on the pictures itself. So on this one, you can see the 3 waveforms very nicely. You can see the P1, P2, and P3. On this one, sorry, I've just got the Zoom thingy blocking my screen a bit. But on this one, you can appreciate that you've got raised intracranial pressure. It should be below 20. So you've got this one significantly raised intracranial pressure already, and you can appreciate that it has an effect on the brain oxygenation. Brain oxygenation should also be above 20 in a patient that's being well managed in terms of adequate brain oxygenation. And you can see that actually here on this one, the P2 wave is higher than the P1, and you've got decreased brain compliance, which actually signifies, you know, this brain is quite swollen, and we are struggling here to get control of the patient's intracranial pressure, and it has started to affect the brain oxygenation or brain oxygen delivery. Next. Okay, this is an example of hyperemia. If you guys have ever heard us on the ward round talk about, but this response is a hyperemic response. It usually also, we've alluded to this 3 weeks ago in the part 1 talk, where you can have raised intracranial pressure with brain swelling. So if you guys can remember that we spoke about the difference between when we refer in trauma between brain swelling, which we kind of just implies loss of autoregulation, and you just have this vasodilatation and all this blood flow through the brain, but it does push up the intracranial pressure, but it doesn't actually mean you've got adequate oxygenation of the head injury. You've got this hyperemic response of just blood flowing through. You've got loss of autoregulation. The brain starts to swell, and it's also not great. So you mustn't think that, yay, the LICOX is 50, we must be doing very well. This is actually a hyperemic response, and it's not so great. It just signifies loss of autoregulation and significant brain swelling. This is one of our patients that if you actually do manage to get in an external ventricular drain in a trauma patient, you can actually use the EVD on our neon codon monitors to kind of get the same type of tracing. This is actually our EVD that we've hooked up and zeroed the same way that you would for a CVP or even an A-line, and you can get that same tracing on the neon codon, and you can measure there, and here you can see you've got a measurement of 17, so this patient's not doing so badly. This is an example of what it looks like. So here you've also got like uncontrolled intracranial pressure with raised pressures of 41. So this patient's really in a whole heap of trouble. And as you would expect, the LICOX is very, very poor. So there's actually the LICOX monitor at the probe where it's inserted, it's not reading anything in terms of oxygen at the probe, and often this is not wrong, the probe is not broken, but you can imagine if you don't actually have adequate cerebral blood flow through the brain is going to cool down. So this temperature of 32.6 is actually the brain temperature, not the core body temperature, and you would see that there's quite a marked discrepancy between the core body temperature probe and the temperature being measured through the LICOX monitor in the brain. Okay, this is the example that I wanted to show you guys with the loss of autoregulation and how you can actually just drive the ICP up by just an adrenaline infusion. So this is a patient that had a significant head injury, had complete loss of autoregulation, and sometimes you can see it on an ICP monitor. So this one, you can see the ICP monitor here reading 72. This is an adrenaline infusion running, and this is to kind of try and maintain cerebral perfusion pressure. We usually aim for between at least 50 and 60, but you can see here that all the adrenaline is doing with a map of 74 is it's driving the same amount of ICP. Usually the ICP lags behind about 2 seconds, which is why the 72 and the 74 is not exactly the same, but I mean, maybe for the next time if I come across this, I'll take a little video shot, and you can see as you bring the adrenaline down, the ICP comes down, and as you drive the adrenaline up and you drive the blood pressure up, the ICP goes up with it. And then you can also see the LICOX just kind of confirms to you that you've got absolutely no oxygenation of the area where the probe is. You just also have to remember that the LICOX probe is only measuring the oxygen around the probe tip. So it's only one spot in the brain. So we kind of extrapolate it to what's going on in the rest of the brain. But it's not very useful if you put the LICOX probe in a contusion or in an area of infarct, because it's not going to give you an idea of how the rest of the brain looks. So we do use a bit of extrapolation when we look at that, and that's why a post-ICP monitor placement scan is so useful, so that you can at least know exactly where the tips are sitting and how you can interpret them. Then I didn't have this in because Lundberg waveforms are quite archaical. It doesn't help you that much, but you guys apparently still get asked this in your part 2 anesthetic exams. And all I will say, so this is a little summary for you, and I can't see that you need to know more about Lundberg waveforms than this. There's mainly 3 types, the Lundberg A, B, and C waveforms. The dangerous ones are the Lundberg A A waveforms, and this is what they look like. They are these waveforms that you have a baseline pressure. It's usually in patients with significant head injury and you are struggling with brain swelling. And you get these time periods. They usually can last anything from 5 to 20 minutes of sustained intracranial hypertension, and it can be anything from 50 to 80 millimeters of mercury. And if your patient doesn't herniate and die from that pressure, you get this pathological waveform that you've got this raise. It'll be sustained for 5 to 20 minutes and it'll come back to its baseline of still raised ICPs. And it may represent cerebral vasodilation due to a decrease in the cerebral perfusion pressure. But what it means is you need to urgently actually try and control this patient's intracranial pressure. And you need to make sure that they're on anti-epileptics. You need to make sure that you're doing all the right neuroprotective measures, which we will chat about also now, and make sure that you can sort out this patient's raised intracranial pressures. A Lundberg B waveform, not so dramatic, can still have the same wave pattern. So you have a baseline of a lower intracranial pressure where the pressure sits most of the time, but you have these shorter time periods where the ICPs go up. It's usually a short time period. The ICPs, what is important, what makes a difference to a Lundberg A, is that it's more an oscillation type pattern. It will never be as high as 50 to 80. It will remain at least below 50 millimeters of mercury. And they are short time periods. They usually go up for a short time and it'll come spontaneously back down. It has been associated with normal breathing patterns, and if patients are being manipulated, getting chest physio, being turned, the important thing is that these intracranial hypertensions come down spontaneously. But you can actually, if you do see this pattern on the trend section of an ICP box, you can actually adjust your treatment, and especially if a patient's going to get chest physio, give them bolus sedation before, suctioning their ET tube before they get chest physio, so that you can try and prevent this, because during that time period, their cerebral perfusion pressure will go down. The Lundberg C waveforms look literally like this little tooth saw oscillatory pattern. They're small oscillations between 10 and 20 millimeters of mercury variations, and they usually have like their own little oscillation rate of about 4 to 8 waves a minute that they will run through this swing between 10 and 20, and that's really just been associated with systemic arterial pressure changes, and it's considered to be normal. And now, unfortunately, the only clinical example that I could find to you guys is an example of a Lundberg C. And this is just on the trend section. If you actually, on our boxes that we have here at Christel, you just click on the trend window. You can change the amount of, if you want to see 2 hours, 6 hours, 12 hours, 48 hours, and you can actually start to see the pattern, the waveform pattern. And this more looks like a Lundberg C waveform pattern than any of the others. Okay, getting more to the actual good stuff. So the treatment of the traumatic brain injury, obviously the bread and butter for treatment of TBI is the Brain Trauma Foundation guidelines. It's currently in its 4th edition that was published in 2016. And it's an international collaborative project that publishes guidelines almost every 4 to 5 years. So we are due for a 5th edition either this year or probably maybe next. I suspect with all the COVID that things have been delayed quite a bit. The Brain Trauma Foundation guidelines, we'll go through now as well. And then just to remember that the treatment of a TBI patient usually is a tiered approach. There's no protocolized way you must do step 1 before you do step 2. There's no use in you trying to straighten out the patient's head and make sure the trachea isn't too tight around the patient's neck when, actually the repeat scan showed a massive recurrence of an extradural hematoma. Then obviously you would rush to theater before you go fiddling around with the trachea tape. But it is one of those circumstances where you try and do multiple things all at the same time. There's a few physical maneuvers that we can do to try and prevent secondary brain injury and treat traumatic brain injury. There's a few medical maneuvers that we use, and then there's obviously surgical surgical treatments that we also use to manage traumatic brain injury. So this is a photo that I just took off the internet. So this is why this guy's eyes are not blacked out. This is the line that I just took the photo, but I just thought it depicted very nicely all the things that you can fiddle with from a physical point of view to try and improve ICP control. So first things, Philadelphia collars are not great for venous drainage of the brain. So if it's not necessary, try and remove them. These patients are not going to thrash around. They're often on high-dose propofol, high-dose morphine infusions. So if you're doing an adequate job with your sedation strategy, if there isn't an obvious C-spine injury, then we try and get rid of them if there isn't a spinal cord injury, just because they affect the cerebral venous drainage. Make sure that our patients are always head up 30 to 40 degrees. It does make a significant difference to the intracranial pressure, sometimes so that in the neuro ICU, if it's time for a central line change and a patient has got very difficult or very refractory ICP that we're just struggling to get on top of, it is not the type of patient that we are going to lie down to try and now move the subclavian line to an IJ line. It's more the situation where we would leave the patient in the 30-degree head up and not take chances to worsen the intracranial hypertension, and we would rather go for a femoral CVP. So to try and move and manipulate the patient as little as we can. Ensure that the head is straight. This sounds very simple, but it actually makes a massive difference. If you actually turn a patient's head to the side, you're impeding the venous drainage from the internal jugular from that side, and it can actually make a massive difference with how well you can control the intracranial hypertension. We've already spoken about the neck collars, so if there's no C-spine injury, please remove them as soon as you can. And don't forget to check the trachea tape, especially if they get taped below the ears. They occlude the internal jugulars quite adequately. So if your trachea tape is too tight, just try and check that. And if you loosen that, you might find that the ICP actually improves a bit. Okay, a few things on the Brain Trauma Foundation guidelines. So there's 15 points in the Brain Trauma Foundation guidelines on how to manage patients with traumatic brain injury. I'm starting with the surgical one. So in terms of decompressive craniectomy, the Brain Trauma Foundation guidelines do actually, so this is just a little table that I've summarized it on, but the Brain Trauma Foundation guidelines is actually like a nearly 200-page document about all the class 1, class 2, class 3 recommendations for all of these 15 points that we're going to run through very quickly. But when they talk about decompressive craniectomy, there's lots of trials that's been out, Rescue ICP and DECRA, and a lot of good studies that have been published, all with different difficulties in their research methodology, and people kind of writing back and having some issues with how it was done and how patient selections were done and how you randomize, because there often ends up being a lot of crossover from one randomized pool to the control group, or the control group crossing over to the surgical group. So it's very difficult to actually run these trials like ethically. So a decompressive craniectomy will help you control ICP monitors. That's just pure logic. I mean, if you take the lid off the box when the box has run out of space, the pressures will come down. But what it has been shown is that the Brain Trauma Foundation guidelines doesn't recommend it to improve outcomes. You will increase your survivor number, but they've looked at the analysis of the survivors from decompressive craniectomies, and basically the bottom line is that you're going to make more survivors, but they are the survivors with the worst functional outcomes, so with the lower Glasgow outcome scales. What else it does is it does shorten the ICU stay for a patient, and you do end up using less ICP targeting interventions. That means like you do end up using less hypertonic saline or mannitol or whatever it is that you use to try and control the ICP. The recommendation on prophylactic hypothermia is basically, bottom line again, it doesn't improve outcome. Okay, there's lots of debates we can have about this, and maybe we can have some talks about it on the rounds, but it doesn't improve outcome. Okay, and this is specifically now for traumatic brain injuries. Okay, I'm not talking about post-cardiac surgery arrests and things like that. I'm just talking about traumatic brain injury. Osmotherapy, so in the current the latest Brain Trauma Foundation guidelines, it's still mannitol over hypertonic saline, but I have a very strong suspicion that in the newer guidelines or the 5th edition that'll come out, hypertonic saline will probably overtake mannitol in its recommendations, just because of all the latest literature that has come out around hypertonic saline. But mannitol is still great. And it will buy you time when you are rushing a patient to theater to evacuate that extradural. And it's great for various reasons. And I will talk specifically a little bit about mannitol versus hypertonic saline in a few minutes. There's also some recommendations on draining CSF. So if you do manage to, in a severely swollen brain that almost has unhittable ventricular sizes, manage to get in an EVD, there's some recommendations whether or not it's better to kind of leave the EVD clamped and only open the EVD when the ICPs go higher, or should you just set the EVD at a certain height and leave the EVD open on continuous drainage? And the recommendations from the Brain Trauma Foundation guideline is actually that continuous drainage is better than intermittent. So just set it at a certain height that you want 20 centimeters or 18 centimeters, and you want to just rather continuously drain CSF when the pressures hit above that. On ventilation, they're quite clear that you should avoid hyperventilation, especially in the first 12 hours where you still have penumbra areas that are very dependent on cerebral blood flow. And if you're going to hyperventilate somebody, like we've said before, you're going to cause vasoconstriction in the cerebral arteries, and you're going to just worsen those penumbra areas that are very reliant on the little bit of blood flow that they are managed to get. Like I said, though, there is still a space for it. It is going to save you if you need to buy a few seconds whilst you are doing something else to try and sort out a patient, whether or not that is rushing the patient to theater to evacuate the hematoma or to treat whatever the pathology is driving it, or for you to kind of get another bolus of hypertonic saline running. It will buy you a few moments, but just to realize that you shouldn't do it for prolonged periods, like maybe 60 to 120 seconds at most. You shouldn't do it for, kind of just set the rate at 30 and tidal volumes of 600 and drive the PCO2 down to 2 and just leave the patient like that. We do try and aim for a PCO2 level of between 4.1 and 4.3 to kind of just keep normocarbia. So we don't use hyperventilation for that. Sedation strategy, propofol is still routinely recommended for, just remember these are adult TBI patients. There are different Brain Trauma Foundation guidelines for the pediatric population. And we don't really routinely use barbiturate comas anymore, and they really are reserved for the super refractory ICP patients where you still think there could be some decent chance of a decent prognosis. So in all of the Brain Trauma Foundation guidelines, the only level 1 recommendation is regarding steroids. And basically the long story of steroids is just that in acute head injuries or severe traumatic brain injuries, steroids are bad. We don't use them. Okay, so we will use them if there's secondary septic shock. We will use them as we would normally for any other patient with septic shock that goes into shock that has increasing requirements of adrenaline. But for a standard traumatic brain injury, we don't use steroids as part of their treatment for that. Nutrition is basically the same as most of our ICU patients. We do try and establish full nutritional requirement feeds as soon as possible. For our isolated head injuries, it's usually not a problem. We can almost start them nearly immediately once we've confirmed placement of the nasogastric or the orogastric tube. And most of the isolated head injury patients tolerate feeds quite well, quite early on. So the 5 to 7 day grace that the BTF guidelines recommend is usually not an issue to get to. Prophylactic antibiotics, we don't use it routinely. And from a neurosurgical perspective here at Christel, we don't use them routinely for open penetrating head injuries, open penetrating spine injuries. We don't use prophylactic antibiotics. If we feel that we need to treat something, we'll treat. But other than the standard Kefzol that we get when the patient goes to theater, we don't continue with any other antibiotics. DVT prophylaxis. We had another discussion about that this morning in D12. So Christel neurosurgery, we're quite conservative when it comes to DVT prophylaxis. It depends a little bit about your center and how busy your CT scanner is. Our CT scanner is quite busy, and to move our patients from ICU, we never want to do it unnecessarily. We all know a trip to the scanner for an ICU patient is a fairly risky thing to embark on. So we here at Christel, we know we're very conservative. We tend to not institute chemical DVT prophylaxis until about day 10 to 14. It does obviously depend on the type of pathology that is on the brain scan. And we just use a mechanical DVT thromboprophylaxis. So all of our patients get DVT stockings and pneumatic compressive devices. And we kind of assess patients on each patient basis as to when we start chemical prophylaxis. When we would start it earlier is if there isn't really that significant of a intracerebral hematoma, and we've had a repeat scan to prove that there's no new bleeds or no ongoing bleeds on compared to the admission scan, then we would feel a little bit safer to start prophylactic Clexane. Like the patient that we were discussing this morning, she had a diffuse brain injury with very little traumatic subarachnoid blood and one small tiny gliding contusion, and she had a follow-up CT brain scan which didn't show any new bleeds, and she's only day 4 in ICU today. So we started her on Clexane, but that's, like I said, she's not really a massive risk, and kind of it's always a risk assessment decision that you have to make. You have to kind of decide whether or not you're going to risk the patient developing a DVT and a massive PE, or if you're going to risk another intracerebral event. The other patient that we then discussed was the patient that had the massive subdural hematoma, went back to theater twice, also had a massive intracerebral hematoma that was drained. He's also only day 5, and I mean, we've elected not to start him on DVT prophylaxis. We will probably wait until about the day 14 mark before we start chemical prophylaxis. But he is on TED stockings with pneumatic compressive devices. Seizure prophylaxis, the BTF guidelines is usually 7 days of IV phenytoin to prevent post-traumatic seizures. And after that, you usually try and stop them and see if there's any recurrence of seizures, then we would restart. And usually if there's recurrence of seizures, then they are usually committed to about 3 to 7 months of an anti-epileptic before we'll decide to try and wean it off again. ICP monitoring we already spoke to, but those are the BTF guidelines of GCS level and CT scan findings. Cerebral perfusion pressure monitoring. So they do recommend that you use a cerebral perfusion guided management strategy, and that you should always try and aim to use to meet a cerebral perfusion pressure of between 60 and 70. Sometimes here we will tolerate a cerebral perfusion pressure of 50. But that being said, most of the time we manage 60 to 70 quite well. And then advanced cerebral monitoring. So currently there's no support for any other monitors. This includes actually a Lycox monitor. But like I said, it's quite helpful to sometimes see that, you know, even though you get an adequate cerebral perfusion pressure, it doesn't mean you're oxygenating the brain well, and it doesn't mean that you aren't in that phase where you've got complete loss of autoregulation and you're in a hyperemic stage. And then the Brain Trauma Foundation guidelines do also include systolic blood pressure targets for various age groups, and I've left them there for your study. Okay, then a few things that we'll very quickly run through. I'll also just mention 1 or 2 things, but I've typed out the table so that you guys can use it as study notes. But just a few things on hypertonic saline versus mannitol. So here at Grooteskier, if a patient comes in to trauma front room and we need to, with a pupil that's like blowing in front of you and you need to get this patient to CT scanner and theater as quickly as possible, mannitol is very useful. You can run it as a bolus, as a stat in, and we usually use 1 gram per kg as a loading dose, and you can repeat another 0.5 gram per kg as a second dose then if you need to repeat the dose. So it's very useful. You don't need an infusion pump to give it, and it will help you. The better one, however, is a hypertonic saline. But, and the mannitol you can also just run through large bore peripheral IV. So gray or orange gelcos work well with mannitol, whereas the hypertonic saline, it's better to give it through a central line and to run it then obviously through an infusion. You can't really give hypertonic saline as a bolus. You are going to risk pontine myelinosis if you do that. The hypertonic saline that we have at Grooteskier is a 5% solution. So just to realize and put that in perspective for you. So everybody always like, this is the neurosurgeons because we like our abnormal saline. But the sodium content of normal saline is 150 milliequivalents in that liter that you give in a saline bag. The 5% hypertonic saline has 856 milliequivalents per liter. It usually comes in a glass bottle of 200 mils, and we usually run it as an infusion over 4 to 6 hours. So it isn't something that you can just kind of give as a stat bolus and, you know, rush to theater. The rest of it you can just kind of read through. This is just for your studies in terms of, and I've kind of very briefly just spoken about some of the advantages that you can use, and then obviously some of the disadvantages and risk factors using it. So evidence on hypertonic saline versus mannitol, I've already told you, I suspect that in the 5th edition of the Brain Trauma Foundation guidelines, but I may very well be wrong. But I think hypertonic saline is going to be preferred over mannitol. And there's been lots of literature coming out of late that kind of is in favor of that. But that being said, I've highlighted in red the line here from the article that I've left here for you guys as reference. There are indications that hypertonic saline might be superior to mannitol in the treatment of traumatic brain injury-related raised ICP. However, there is still insufficient data to research a definitive conclusion. So it'll be very interesting to see what comes out in the newest edition of the Brain Trauma Foundation guidelines in terms of this ever so debated hypertonic saline versus mannitol. Just one word on anticonvulsants. So typically here for traumatic or post-traumatic seizures, phenytoin works very well. I know it's an old drug and it is a bit of a dirty drug, but it is very potent and very good at controlling post-traumatic seizures. So generally, our protocol here is that our patients that come in with severe TBI get loaded with 1.2 grams of phenytoin. We usually mix it in a 200 ml normal saline bag and we run it over 30 minutes. If you give it as a stat bolus, the patient may have like quite a significant hypotensive reaction. If for some reason you can't use or you don't want to use phenytoin, Epilim is a very good alternative, or sodium valproate. We also load between 1 to 1.2 grams of Epilim. We use it because especially in the patients that have already raised intracerebral hypertension, if they have a seizure, the seizure usually causes quite a significant spike in the ICP, and that alone could be enough to cause a brain herniation event. So it's really very important that before you even think of giving mannitol or hypertonic saline, that the anticonvulsant should have already gone in. Then I've also just for study purposes, there's a few things that you can just read up on phenytoin and Epilim, but I see I'm running out of time, so I'm just going to leave that for you guys just to study, but I've summarized that for you. We do use our sedation strategy is an analgo sedation strategy. We do like to use morphine infusion, and then we usually add propofol infusion on top of that if we need to. We've moved away from midazolam infusion just because of all the studies that have come out, linking the benzos to increased risk of delirium, and delirium being directly linked to an increased in mortality. So even on the traumatic or the neurosurgery side, we've moved away from benzo infusions. If we really have somebody that we can't control on propofol and morphine infusion, sometimes we will revert to maybe using midazolam boluses, but that's only in very, very rare cases. And I've just placed a little picture. So, I mean, we do tend to use quite high doses of propofol, and we run anything from between 5 and 25 moles an hour of propofol. Again, just to remind you guys that this is in an adult neuro ICU, not a pediatric, which we don't use propofol infusion in kids just because of the propofol infusion syndrome. But here you can already appreciate the blue discoloration in the urine, and this is actually a patient that's on 15 mils an hour of propofol. So not that huge amount, and you can already appreciate this discoloration of that benzoate ring that causes the urine discoloration. Okay, treatment of TBI in terms of the surgery. So we usually try and evacuate what can evacuate in terms of intracranial hematoma through a craniotomy. Just to also remember, a depressed skull fracture can also cause significant mass effect on the brain itself. And we usually alleviate that by a craniectomy. So often we have to elevate the bone fragments and then toss the pieces away, especially if it's an open wound. And then we continue with neuroprotection in our units with the head elevation, maintain adequate cerebral perfusion pressure, ensure adequate blood pressures, and try our very best then in the ICU to control our our intracranial pressures. This is just an example to show you how an depressed skull fracture can actually, and this one's actually quite mild, but here you can see a 3D construction of an axe assault. And you can see that it actually causes significant mass effect on the brain, and you can't actually leave that alone. You actually have to elevate this, and that this has nothing to do with cosmesis, although cosmesis would be secondary. But actually to treat the mass effect on the brain, you need to elevate that bone fragment, as well as to wash out that wound. This is going into the frontal air sinuses, which is obviously a massive meningitis risk to this patient as well. Base of skull fractures, we were all taught this at undergrad level. So again, I'll just leave this notes here for you to kind of just squiz through, but there's some clinical signs that you can look at. If you are worried, especially if a patient is complaining of rhinorrhea and you think that there is CSF coming through the nose, you can always catch a bit of the fluid and we send it away for beta-2 transferrin. And that will confirm, the presence of if that is a CSF leak or if it isn't just like a little bit of a runny nose. Just to show you guys an example of what an external ventricular drain looks like. So it's literally a little drain pipe that goes into the ventricular system. It's connected to a drainage pipe, and you can set the height. We usually use the 0 point as the foramen of Monroe. But I put this picture next to you because putting in an EVD for hydrocephalus is wonderful. Putting in an EVD to use as part of your treatment of traumatic brain injury is very difficult. If you have a very swollen brain, the brain is already trying to sort itself out by shunting CSF out. So you've already got such small ventricles to try and hit these ventricles with an EVD. Is very, very tricky, and like a lot of centers overseas have moved over to using neuronavigation to try and hit those ventricles so that you can actually get into a CSF space. So very useful if you can get it done, but very difficult to actually get it done. Just one word on microdialysis for those of you that might be keen on it, or if you get asked this, like you don't have to know lots about microdialysis. It is not in the realm of treatment modalities for traumatic brain injuries. It's still in the realm of research. There is some use for microdialysis in terms of prognosticating patients. And all the microdialysis catheter it was first used in liver studies, but it's also now made its way into traumatic brain injury realms. And it's just this little semi-permeable little membrane probe that also gets stuck into the brain, much like an ICP and a Lycox monitor. And it actually has this ability to actually, you can sample from the extracellular fluid space in the brain. And you can measure all sorts of things like glucose, pyruvate, lactate pyruvate levels, glutamate. You can even do drug studies. So the guys at Red Cross are doing lots of exciting things with microdialysis, both in terms of taking samples to prognosticate patients, but also especially in kiddies with TB meningitis, to actually see if we are getting adequate levels of the TB treatment drugs into the CSF spaces to treat the TB meningitis adequately. So lots of very interesting things coming from microdialysis. But at this stage, more in the realms of research rather than using it to help us treat traumatic brain injury patients. Recovery after TBI, I really just want to say two things on prognosticating. So we do use something called a Glasgow Outcome Score. And there's also something called a GOS-E, which is the Glasgow Outcome Score Extended. And it kind of just quantifies in a more objective way what the patient's functional baseline is after recovering from a traumatic brain injury. The extended Glasgow outcome score, the GOS-E, kind of just splits this up into more categories. It's got 8 instead of 5, and it just kind of gives you more of an idea of what the upper limb versus the lower limbs can do, because obviously if you're paraplegic, you can still kind of get around with a wheelchair if you've got good functional use of your upper limbs. But obviously, if you've got poor use of your upper limbs, you're a poorer GOS-E than somebody that actually has good functional use of upper limbs. And it's just an objective way of how we can actually quantify recovery after traumatic brain injury. Also, just to know of something called a post-concussion syndrome, and as Murphy's Law would have it, usually the patients that suffer the most severely from post-concussion syndrome is the patients that had the minor head injuries, so the milder forms. They usually sit with the symptoms for much longer periods, and common symptoms around post-concussion syndromes, and it can be quite debilitating, is very severe headaches, sleep disturbances, appetite changes, easily fatigable, complaints of dizziness, photophobia, and quite sensitive to noise, depression and mood changes, memory problems is a big thing for people, and then also inability or trouble with concentration. And there's very good neurocognitive rehab programs that we have. And then the biggest part of recovering from traumatic brain injury is that we're very reliant on our multidisciplinary team. You cannot help a patient to recover from a significant head injury if you don't actually have a good team that you're working with. We've got excellent physiotherapists that work with these patients. We've got specialist neuro rehab, occupational therapists. You need speech therapists. You need adequately trained nursing staff, neurosurgeons, intensivists, as well as neuropsychologists to help a patient really give them the best chance of recovering from a traumatic brain injury. And just to know that this is not something that a patient will recover from in a week or two. This often takes weeks to months and can take up to 18 to 24 months to recover from, where you kind of hit a baseline. And usually the counseling usually goes that usually what you have recovered at about your 18-month mark is more or less where you're going to be then for the rest of your life. So that's more or less that. So sorry about that. That's jam-packed. But if there's anything that I didn't explain clearly or that I left out, you guys are welcome to ask. I don't know if there's any questions.